Good afternoon, everyone. Welcome to today's update on COVID-19 in Alberta. With us, as always, is Dr. Deena Hinshaw, Chief Medical Officer of Health for the province. As well as we have Dr. David Zegan, Zone Medical Director with Alberta Health Services. Dr. Hinshaw will provide a brief update, and then we will open the floor to questions.
Thank you, Tom, and good afternoon, everyone. Before I begin, I want to recognize all Albertans in areas under enhanced status for their efforts in implementing the new measures that came into effect on Friday. I've heard from several faith leaders and many others who made sure to put the new measures into practice. I know that it takes additional effort and attention to make that happen, and I want to thank everyone who has helped limit the spread over the past several days. Throughout this pandemic, a great many people have been working very hard to protect their loved ones and their community. Thank you for this great work, and please keep it up. At the same time, I am also aware of concerning reports about activities in malls and other settings over the weekend. We all must do our part. I recognize the right of people to protest, and we have issued detailed guidance to help Albertans do so safely. I encourage Albertans to follow this guidance to keep each other safe. Turning to today's update. Over the last 24 hours, we have identified 1,733 new cases of COVID-19 in Alberta and completed about 20,500 new tests. This means that our provincial positivity rate currently sits at about 8.4%, and we have 16,454 active cases. There are 453 people in hospital. Of those, 96 are in the ICU. Sadly, there were 8 deaths related to COVID-19 reported to us in the past 24 hours. My thoughts are with everyone who knew and loved these individuals as they mourn the passing of their parent, sibling, loved one, or friend. I also offer condolences to all those who are mourning the loss of a loved one today from any cause. Turning to schools, there are currently active cases, active alerts or outbreaks in 376 schools, or about 16% of schools in Alberta. Currently, these schools have a combined total of 1,405 active cases. This number includes 203 schools with outbreaks, including 88 currently on the watch list. With students in grades 7 to 12 moving to online learning today, we can expect to see a reduction in the number of cases, outbreaks, and alerts attributed to schools in the coming days. I do want to be clear, there is a lag time between actions and results. While cases may not be attributed to schools as students are at home, they will still be reflected in our overall active cases. Like all Albertans, I am alarmed by the rising case numbers reported today and over the weekend. This is another reminder that COVID-19 has a long incubation period, meaning the actions we take today will not be seen until 10 to 14 days from now. I suspect that we will continue to see cases and hospitalizations rise over the next several days as we wait for the impact of the restrictions that were announced last week. Each of us must remain more vigilant than ever. We need to bend the curve and lower the number of active cases now to protect each other and the health system. I know we are all feeling a lot of different emotions about where we are right now. Anger, guilt, fear, sadness, denial, and bargaining are all common themes. As I was reminded recently, these are the stages of grief, and we need to give ourselves permission to experience whatever emotions show up for us. Experiencing these emotions is a normal part of grieving all that we have lost to COVID-19. These emotions do not mean that we have lost the battle, just that it is a hard one to fight. The more we can support each other to keep going while acknowledging the difficulty of these days, the better off we will all be. As I've said before, there is no silver bullet to combating COVID-19. It takes a number of efforts together to minimize transmission, including physical distancing, wearing masks, and practicing good hand hygiene regularly, and we need to continue with these for months to come. I know this can seem overwhelming, but I need every Albertan to focus on how they can change their lives right now to protect their communities. This pandemic has been here for months now, and we have all formed habits with respect to how we navigate our daily lives. The growing spread of COVID-19 touches every part of our province and society. I am very concerned about growing outbreaks in continuing care facilities and met with operators and staff last week to get their input on how to move forward. We also continue to see a growing number of other outbreaks, including a recent outbreak at the Calgary Remand Centre. There are now 41 active cases linked to this outbreak. AHS is working closely with local officials to make sure that strict outbreak protocols are maintained and aggressive testing is underway. AHS is also working to support the outbreak at the Edmonton Convention Centre. We take any outbreak in a congregate living setting very seriously, and my local health colleagues are working to ensure that anyone at risk is tested, isolated, and properly supported. As you know, last week we announced new measures to reduce community spread, many of which came into force on Friday. As I mentioned earlier, we can expect it to take about 10 to 14 days to start seeing results. This means the actions we all take this week will help shape how the virus is spreading in the lead up to the holidays. Bending the curve is critical to protecting those most likely to experience serious outcomes from the virus. But I want to remind everyone, we are all at risk of COVID-19, women and men, young and old. Recovery can be slow for many, lasting weeks or months, with countless ups and downs throughout. And long-term health impacts for those who get the virus remain unknown. I have heard directly from people who are facing lasting effects. And while we're still learning about COVID-19, it's clear that for a significant number of those infected, there is a range of serious long-term effects. These symptoms can change over time, can affect different systems in the body, and can often overlap, which reminds us that the impact of the virus can last long after a person is contagious. By minimizing the spread, we are not only preventing someone from having to isolate at home while they're infectious, we are also sparing them from a long list of challenges that could impact their long-term health and their quality of life. This week, we all need to be more vigilant than ever in limiting our contacts with others and slowing the spread of COVID-19. I know this is a difficult time, but we are still all in this together. Thank you, and I'm happy to take questions.
All right, we'll go to the phone now. Friendly reminder that in addition to Dr. Hinshaw, we also have Dr. Zegan with Alberta Health Services. Operator, could you put through the first caller, please?
Thank you very much. The first call is from Kevin Nimick, CTV Calgary.
Hi, Dr. Hinshaw. Over the weekend in Calgary, there were 2 large gatherings of anti-mask protesters. Were you disappointed to see minimal enforcement based on what you had said on Friday?
It's important to remember that there is a democratic right to express concerns and, again, protests. We have issued guidance with respect to rallies and demonstrations that includes measures for how individuals who are wanting to express their opinions can keep themselves and others safe. It's important to be able to balance those rights of protest with the need to keep each other safe. And I would reiterate my statement from earlier that the guidance for rallies and demonstrations was put together with the intent of balancing, again, the rights of expression with the need to be watching out for our communities.
Operator, could you put through the next caller, please?
Thank you. Yes, Robson Fletcher, CBC.
Hi, Dr. Hinshaw. I was going to ask you this question, but I would also be interested if Alberta Health Services might want to weigh in on it, as it may relate to them. But a colleague had asked last week for data on the racial or ethnic backgrounds of Albertans who have been diagnosed with COVID-19, and was told that this data is now being collected but not yet being released. Today, the Premier's Issues Manager tweeted some of that data, saying that Albertans of South and East Asian descent account for just under 20% of COVID-19 cases, despite representing only 11% of the population. I'm just wondering more about this data. When did Alberta start collecting it? How is it being collected? I understand it might be through contact tracers. And why is it only being released in snippets like this so far instead of its entirety?
We have been working to improve our collection of data on self-identified ethnicity since the spring, and the numbers that you're referencing are preliminary. We have been working over the past several months on putting that data together and doing some analysis so that we would be able to communicate it as a comprehensive whole with complete analysis. That's not complete at this time. And it's really important to remember that single numbers that are released should never be used to stigmatize particular communities. There are many reasons why individuals who self-identify within a particular ethnic group may be overrepresented, and that could have more to do with occupation or with other factors in those individuals' lives, and it absolutely should not be taken to infer any kind of blame or stigma on particular individuals. So we are, again, working to complete that analysis. I will note that with the challenges in the recent numbers over the past month and the ability to complete full case investigations for every case being hampered by the volumes, we will not have reliable ethnicity data for the month of November. And we will be, again, working to analyze the data that we have prior to that for the purposes of providing that when it's complete. I don't know, Dr. Zagan, no, okay.
Operator, could you put through the next question, please?
David Staples, Edmonton Journal.
Hi, Dr. Hinshaw. So we know from, I guess, this preliminary data that some ethnic groups and religious groups have different rates of COVID infection than other groups. But what are the challenges in terms of targeting messages to those groups so that you get through to them and change behavior while not stigmatizing them? How have you attempted this challenge?
At a provincial level, we have made sure that the materials that are available on our website, as well as printable materials and materials that are being made available throughout the province, are available in many different languages. And we've worked with Alberta Health Services and the local public health teams who have been making direct connections with individuals in different ethnic communities. And I want to make clear that, again, this is not to indicate that different ethnic communities are to blame for spread, but rather that we want to make sure that everyone has the ability, the knowledge, the supports and resources to be able to protect themselves, their families, and their communities. And so local public health has been working both directly with different community organizations that serve ethnic communities, as well as community leaders themselves. When there's been a specific outbreak that's involved a community leaders in those different communities have been extremely helpful in working as bridges between local public health and their community members. And building those relationships over the past many months is something that, again, local public health has been working very hard to do. We are looking at whether or not we can help support those relationships, the resource provision, and other options, but those are the kinds of things that have been happening over the past several months.
Operator, could you put through the next question, please?
Jesse Weisner, Global TV, Calgary.
Oh, hi. This question is for Dr. Hinshaw. A memo from AHS says hospitals need to reduce the demand on the bulk oxygen system, and everyone needs to engage in conservation measures immediately. What kind of impact could these measures have on patients, and how grave is the situation? Some doctors are saying they've never seen a memo like this before.
Thank you for the question. I will reiterate that the impact on the health system of COVID-19 is exactly why we have measures in place and exactly why all Albertans must act to control the spread. But the details of that particular memo I will pass off to Dr. Zagan to comment on, as he'll have better understanding of the details of operations than I will.
Thank you for the question. First of all, I want to assure Albertans that we do have an adequate oxygen supply in Alberta and indeed in the Calgary zone. I think that throughout the pandemic, we've planned for all needed supplies and are obviously monitoring this. We're being proactive in conservation memo. Having said that, the advice offered to clinicians in that memo is really an evidence-based, responsible manner that we hope that all our frontline is following and making them aware of the need for conservation during this time. This is anticipatory work, and we look at all of our supplies. I think Albertans are well aware of how we've been monitoring our PPE supplies, which are also in good stead, and we will continue to monitor this. Again, want to emphasize that we do have adequate oxygen and are monitoring this very frequently.
Operator, could you put through the next caller, please?
Carrie Tate, Globe and Mail.
Hi, Dr. Hinshaw. Can you explain to us how the severity of outcomes is changing, especially for young people, as the hospitals get backed up?
Thanks for the question, and I'm going to assume that we're talking about severity of outcomes, not just for COVID-19, but potentially severity of outcomes for other conditions as well. I think it's important to remember that for COVID-19, we have seen approximately the same age-specific hospitalization rate since the beginning of the pandemic, meaning that if an Albertan is infected with COVID-19 today, or if they were infected in April or May, they have about the same risk of needing hospital care for COVID-19 all along the way. And so while we have seen some decrease in our age-specific fatality rates for those who are diagnosed with COVID, that is likely because we have a better understanding of the kinds of treatments that help people to do better with respect to COVID-19. And as we see our hospitals starting to become more under pressure, at this time, again, there is adequate capacity to care for all those with COVID. And AHS is making plans to ensure that they are able to flex and accommodate that. However, we do need to make sure we're bending the curve early enough that we never get to that point where we don't have capacity to care for everyone, because we know that adequate acute care is an important reason why our age-specific case fatality rates have come down since the start of the pandemic. And so again, we are seeing that the impact on hospitals has gone up as we've seen our cases rise, exactly because of that maintenance of the hospitalization risk for every person who gets COVID.
Operator, could you put through the next question, please?
Dean Bennett, Canadian Press.
Thanks. Question, I think, for Dr. Hinshaw and Dr. Zegan. It's on the ICU. I wonder if you can expand on some of the comments the Premier made today on 770 re-ICUs. He said 3 points. We're going to see some new numbers this week. What are we going to see? And also he said that there was a meeting today and we've got 91% capacity in the major hospitals, and that if the rates don't change, we're looking at, quote, widespread non-urgent surgical cancellations. Can you expand on those points, please?
I'll just make a general comment and then maybe ask Dr. Zegan to comment more on the specifics from that AHS side. But I would say that we can see hospitalization numbers and ICU numbers rising over the past several days and weeks. And we're now sitting, as you know, at over 400 in hospital and over 90 in ICU. I'll reiterate a point I made last week, which is that in the average influenza season, at the peak of influenza season, we have on average about 30 patients in ICU with influenza. So we're at triple that already. And if we have continued spread, we are nowhere near that COVID-19 peak unless we can collectively bring our numbers down. I'll ask Dr. Zegan to comment on the specifics, but the point that I would make is that these are exactly the reasons why we all need to work together to minimize our spread.
Thanks, Dr. Hinshaw, and thanks for the question. So maybe take a bit of an opportunity to explain what Alberta Health Services is doing to increase the capacity. There's no doubt that the hospital system is under significant strain. Having said that, we've planned extensively for it, and we are executing those plans as the demand increases. As Dr. Hinshaw has told us, we do expect with these numbers that added demand will come over the days and weeks, which certainly emphasizes the importance of taking actions today with the public health measures so that we can manage capacity down the road. So how have we accomplished that? And we have several strategies to accomplish this. First, I'll talk about the ICU. So we have 173 general adult ICU beds in the province. And over the last week in Edmonton, we've added an additional 20 beds. And over the weekend in Calgary, we have another 10 beds. We have plans to expand that up to a total of 425 ICU beds. In hospital, we're also maximizing our occupancy by cohorting patients, by using decommissioned spaces or other spaces that aren't being used at this point in time, and planning for an additional 50 beds in total for this response. Obviously, we hope that they won't be needed, but we are working not only to supply them, but also to staff them. The final point I'd like to make is we're also working in conjunction with our community partners, and that's primary care as well as continuing care, to maximize the space available in the community so that we can take patients who are in our beds right now and put them in the care spaces that are ultimately needed. So there's the acute care spaces that are available. Thank you.
All right, we've got time for 3 more questions. Operator, could you put through the next one, please?
Alicia Corvella, Postmedia.
Oh, good afternoon, Dr. Hinshaw and Dr. Zegan. I have 2 questions, and perhaps both of you could weigh in. The first is Premier Kenney announced just a few days ago that the province is shopping for freezers for the vaccines that require minus 80-degree temperatures. Are you at all concerned that this is too late to be looking for these freezers? My guess is that there's been a run on them, and should the government have been shopping for these earlier, or is it AHS that shops for this? Or I guess the question is, why have we waited this long, since we've known since about August that these vaccines might need this kind of temperature control? And secondly, Premier Kenney announced this weekend that not only would he not make COVID-19 vaccines mandatory, I'd like you to comment on that, but that he's changing the law so as to make that option impossible under his government to have mandatory vaccines. And whereas that might not be a problem with COVID necessarily, COVID-19, because, the death rate's about 3%. But if we were to come down with, say, MERS or something, which is 30%, then I would think that we would want to make that mandatory. And just wondering what your thoughts are on that.
Sure. So first of all, I would say that we haven't been necessarily speaking about all of the different pieces that have already happened to underpin and prepare for the vaccine response, but that doesn't mean they haven't been happening. And so while it's only recently that the freezer procurement was discussed publicly, that's actually been underway for quite some time. So I don't want to leave the impression that we're only just now starting to shop for freezers. That's actually been something that's been in the works for some time, and those will be arriving over the coming weeks. So I actually think Alberta's in a very good position when it comes to having the capacity to receive the vaccines that do require that ultra-cold storage. The second question about mandatory vaccine, it's my perspective that vaccination is a health product, and as such, it's something that individuals receive for the benefit of themselves as well as for the benefit of those around them. It is something that in many provinces, they do not have that requirement or that option to make vaccines mandatory. And so under the Alberta Public Health Act, as you mentioned, there has been a provision that under a state of public health emergency, Cabinet could authorize mandatory vaccination. That is the provision that's being removed. My personal feeling on that is, again, that vaccination is something that we offer. Vaccinations that are offered through a framework that ensures that they are safe and effective. And the ultimate choice of whether or not to receive vaccine is up to that individual, or for minors up to their guardian. And that has always been the approach in Alberta. And so I think that given that we've never used that provision, I personally think it's reasonable that that provision be removed, and that we do our best to ensure that Albertans have all the accurate information they need about the safety and efficacy of vaccines, and about the benefit not just to the individual receiving it, but to those around them, and allow them to make that decision. Dr. Zegan, I don't know if, okay.
Operator, could you put through the next question, please?
Thank you. Omar Mosley, Toronto Star.
Hi there. Hi there. Thanks for taking my question. It's kind of a two-part question, and I'm going to put it forward to Dr. Hinshaw and Dr. Zegan, whoever is more appropriate to respond. So it's in regard to the ICU situation, specific to reports about double bunking in ICU rooms. And I believe Dr. Zegan referred to cohorting patients in regards to expanding spaces. So I have two questions. The first one is just a clarification on numbers in terms of, you had mentioned the 173 general adult ICU beds and then plans to expand to a total of 425. I've read reports about AHS adding 400 beds. So I just wanted to clarify that the final number would be 425, not in addition to 173. And then the second question is just in regards to the cohorting. I've heard doctors explain it as not normal, or something they've never seen in their career in terms of having 2 beds in one room. I'm curious if there are concerns that this could affect the quality of care, not necessarily more broadly in the healthcare system, but specific to these patients in critical condition. When you've got 2 patients in one room and then big machines like ventilators, can you explain how that might affect quality of care?
Sure, and thank you for the question. So to be clear, the 173 beds are our conventionally funded ICU beds that operate throughout the province. As we start to expand capacity, we do have some capacity within our current ICU, so unfunded beds, and those are the first beds that are utilized. As the need for ICU beds increase, we will go into unconventional ICU spaces. And first, that would be some of our specialty ICUs that have spaces, so not perhaps in the adult ICU anymore, but perhaps in a cardiac ICU or another ICU that is capable. Once we get to more extreme measures, then it would be really unconventional spaces. And this would be areas like post-operative recovery rooms or operative rooms or other spaces. And obviously the staffing and challenging of those unconventional spaces do present challenges. There's no doubt about that. Having said that, we have planned for both the equipment and the staffing for those areas, and will require at the extremes staff who are familiar with ICU type conditions and the ventilators and the machines that we use in ICU to help staff those areas. So these would be, for instance, post-operative recovery nurses or anesthesiologists to support critical care teams as we do provide that care in those unconventional spaces. I am reassured by the plans that I have seen from our operative services and our critical care planners across the province, and we meet regularly zonally and provincially to ensure that we're first utilizing all of our conventional ICU beds and teams, and we'll only do that unconventional type spaces when absolutely needed, which we hope to avoid with the public health measures and compliance with those. Just a comment on the double bedding. So there are, throughout our pandemic plans, since I've been part of Alberta Health Services, we do have areas which are purposely made for those types of situations where there are 2 headboards in a room with dual oxygen supplies and air supply and the conventional type room for ventilators. As we get further into the unconventional spaces, obviously the space is not ideal, but certainly we feel that we can manage it safely, and that's why we've identified those space as being available for ICU patients. Thanks.
Operator, could you put through the final question, please?
Thank you. Janet French, CBC.
Hi there. Thanks for taking my question. Just to follow up on the last couple, obviously we've heard this target set about increasing the number of ICU beds. I'm just wondering if Dr. Ziegen and Dr. Hinshaw could speak a little bit to how exactly you staff those. I mean, I'm assuming a couple extra 100 people are not trained in critical care. You know, where are the doctors, the nurses, the healthcare aides coming from who are going to be staffing these beds, and what medical services could suffer or, be understaffed as a result of redirecting any personnel to ICU?
Thanks for the question. I think you've identified one of the key challenges as the ICU capacity and demand increases. So first of all, we utilize those providers that are trained and are usually working in ICU environments, and that's physicians and nurses and respiratory therapists and social workers and our rehab colleagues as well. As we expand out, we've obviously looked at those who have recently been in ICU, maybe moved on to other jobs to be redeployed. We've also taken proactive measures to provide training for those in like-type specialties that could support our critical care teams for expanded. So this may be, as I mentioned before, operative room staff, post-operative recovery staff, emergency staff to support that. And what the teams have developed is a sequential level of support such that as the teams expand, we would use those non-traditional providers, but be supported by the traditional providers in that so that we can provide safe and effective care.
Thank you all for joining us. Dr. Hinshaw will provide another update tomorrow afternoon. Have a safe night.